This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. My name is Vahid Sadrzadeh. I'm the host of this podcast. And Brian, today we continue our guest series on Anesthesia Answered. We're talking about a very, I guess you could say controversial topic that's been in the news the past couple of months. Ever since the death of Matthew Perry, the actor. We're going to talk about ketamine, and you have a very special guest that's joining us here via Zoom today.
Yeah, thanks, Vahid. So we have Ankit Patel. We met. I'll let him share how we met, but he's also an anesthesiologist, currently based out of Lima, Ohio. Am I right there? All right, perfect. So go ahead and introduce yourself, Ankit.
So I'm board certified anesthesiologist, medical director of our group, our ERAS program, which we can talk about what ERAS is in the future. I also work with a platform called Surgery Unified, where we really try to collaborate with other providers and talk about best practice content, really staying connected with physicians around the country. I met Brian, actually. I reached out to him on a whim. I followed his content, and I really enjoyed his postings and getting the word out there, educating our people, our public, around some of the misconceptions that are out there, whether it's anesthesia, ER, healthcare in general. Yeah. And so Brian reached back out, and here we are. We're kind of connecting and talking about what's out there today. What's a hot topic that we really want to get ahead of before people come up with their own stories.
Yeah, definitely. I like that.
And it seems like people have, unfortunately, come out with their own versions of why this has happened. But let's talk about ketamine in general. What is it, and how does it work in the context of anesthesia?
Yeah, so there were two things that sparked this. One, obviously, the arrests in the Matthew Perry case, but also I had a follower on one of my posts give me a hard time about comparing ketamine to propofol. And so I'd like to address, it was a 90-second post. I'm trying to describe a bunch of different drugs, right? So I was not inaccurate, but I was not complete. So let's just go ahead and Ankit, you can interrupt anytime.
Sure.
Ketamine is a dissociative anesthetic, does a whole bunch of different things, right? Gives you some sedation, gives you dissociation, so you don't care what's going on, definitely amnesia. And then it's something that we call almost a complete anesthetic, because it also does analgesia. And then it gives you some side effects as well. So it makes secretions more prevalent, particularly in the mouth. It can definitely increase heart rate and blood pressure. So it's a sympathomimetic. And then the other thing it can do is it can increase intracranial pressure. So if you already have a brain injury, it can cause some issues there. But
when do you use this?
So I personally, and we'll get into this a little bit more, don't use it a ton, but we do use it both in the pre-op area and in the operating room. It's just another one of the tools in our toolbox to be able to sedate and anesthetize patients. So what do you think?
And it really came out maybe 15, 20 years ago in the, around that time is when it started to be used. And every year that goes by, we learn more and more about why we want to use it and more about why we don't want to use it. And so, what you might hear is a lot of ketamine clinics popping up. There's a lot of, uses on a micro dosing. And when you use those words micro dosing, you're thinking, okay, that's a safe dose, but it's a controlled setting. It's a safe environment. For the ORs, for the perioperative area, you're right. We use it, for surgeries, and, there's effects afterwards where people say you can hallucinate afterwards. Mm-hmm. And so with the right dose, you can hallucinate for a day or two. And so you have to be very thoughtful about which patient population you use it on. Now, if they're going to stay in the hospital for a couple of days, you've got some time for that stuff to wear out because the benefits outweighs the risk. But with our country's, growing trend of surgeries going outpatient, I work at an inpatient hospital, but 90% of our surgeries go home the same day, right? And that's going to continue going in that trend.
Right.
You're probably more and more concerned about giving those patients ketamine on a moderate dose because you might have a hard time getting them to go home. So Brian, you and I have talked about this a little before, but sending patients home is really important. Sending them home with a very clear, lucid mind is even more important.
Yep.
Right?
What is the dosage, Ankit, that is normally given to patients?
Yeah, that's totally variable, but go ahead.
Yeah, it's a huge spectrum, but the dosing is 1 milligram per kilogram, but that's an intubation dose, right? Mm-hmm. So you've got different uses for it. So you can use a dose like you said, is a complete anesthetic. You can use a lot, and you can do that to intubate somebody, right? They're completely knocked out. Or you can use 50% or 30%. So sometimes 30, 40 milligrams is safe, but you combine it with other drugs, right? It's meant to be added to a group of drugs that you use for pain management or sedation.
So it's
But
it's almost, like a soluble, right? Like you mix it with other things to bring the intensity down. Is that,
well,
as a lay person who is not right? Like,
yeah, and you're not mixing it literally,
Oh,
but you're
at least
mixing it
hey,
figuratively,
yeah.
right? So
Yeah.
it's not mixed in one big vial and just like squirt it in there.
right.
Although
It's
some people do that with propofol, right?
That's
Propa
true.
or Ketaprof or whatever. Yeah.
Ketofol,
Yeah.
ketofol.
Ketafol. That's right. Yeah.
Yeah.
Yeah. Yeah.
So you're right. They add this plus this gives you an overall picture of sedation or comfort. But
Mhm.
30,
Just
40, 50 milligrams is usually an average.
just to share with you. So I hadn't honestly, I hadn't used ketamine in probably 2 years.
Yeah.
On Friday, I was at a surgery center and I had a guy who had come before who had a bunch of vomiting issues. As soon as we get him prone, he vomits. So I didn't want to give him propofol because I didn't want to knock out any of his respiratory drive. I didn't want to knock out his ability to protect his airway. So I gave him a bunch of Versed, which is a benzodiazepine, which we've talked about before. And then I gave him 10 milligrams of ketamine and it was perfect. So 10
Nice.
milligrams is a tenth of the dose I would give to intubate. So
Okay, so let's kind of shift here and just what exactly happened,
with
not the post, but what happened to Matthew Perry that night? How did he pass?
yeah, go ahead, Ankit. We've talked about this a bit.
My understanding was that he goes through, he sees someone that prescribes him some ketamine. And I think when you go through that clinic or process and you've got a provider, it sounds like he got doses and then maybe got more doses. I guess the story will be a little unclear.
And
But
this is to help him sleep, help him
well,
rest.
A little unclear,
I
but
think and I think the answer is we don't know. I think did he
yeah,
have a lot of mental health disorders that it helped with, whether it's depression, anxiety,
yeah,
bipolar? We don't know, right? But I believe that there's going to be proof that that can apply for anybody. These microdosing centers are probably going to say, yeah, it can help with A, B, C, X, Y, and Z.
yeah.
So it's hard to know what he was using it for, but I think he got a certain dose. Comes back to his home, gets in the hot tub, and like I said, these things can make you feel relaxed and depressed in a body sense, not in a mental
Mhm.
state. And then you just kind of fall asleep and your reflexes are kind of diminished,
Yeah.
right? So Brian, is the thought that he kind of went to the hot tub and just kind of slipped in?
Yeah, I think so. You hear about this from time to time with people who, take too much of their pain medication and fall asleep, not exactly the same, or drink too much alcohol and fall asleep in a bathtub, right? You fall asleep and you drown.
Right.
To back up a little bit, there are this microdosing, there are ketamine clinics, there's outpatient clinics where people are using ketamine for things like depression, anxiety, PTSD, even chronic pain. Matthew Perry had a history, and I don't think this is any big secret, right? I mean, he talked about it a lot. He had a history of opioid use and abuse to the point where he had a bowel obstruction, had to have a colectomy, a partial
Mhm.
colectomy. So he was trying to treat all of his disorders without using opioids, and,
Right.
and ketamine can be a good choice for that. So yeah, I would agree. I would think we're speculating, right? But I would
Right.
think he took the ketamine, illicit or prescribed. We're not sure. And we'll talk a little bit at the end about the ketamine queen. But he took it and probably fell asleep in the hot tub and
And
drowned.
drowned.
Mhm.
Right. And I
So
think your reflexes are just diminished. Like you
Yep.
said, normally you'd be like, oh, I'm swallowing water. And
Right.
now you're just like, well, I'm swallowing water. And
Don't care. Yeah.
well, and the reality is he could be hallucinating, right?
Mm.
So when you're hallucinating, you've got this like dream happening, you know, when we're coughing in the middle of the night, we wake up,
Right.
but
yeah.
we're dreaming. But he was just in such a deep state of like just in it, just a deep state of sleep that his reactions and reflexes were just gone.
So why haven't we heard about ketamine clinics before? Well, at least I have not heard about ketamine clinics before. You guys certainly have,
Yeah.
because you're in the field, but to the general public, you really don't hear about these kind of things.
Yeah. Go ahead, Ankit.
It's actually really new. So we're talking the last couple of years, if not less.
Mhm.
that they're trying to pop up, and they're trying to pop up using existing, infusion therapy centers. So you see those around, right? Whether it's IV therapy for chemotherapy drugs
Right.
or hydration or other medications, they're trying to introduce use of ketamine at those facilities.
Mhm.
But I think in the future, you're going to continue to hear more about it. I do believe that this story will probably pause that for a little bit or slow it down to some degree,
Yeah.
because there's going to be a lot of fear associated with that. And a lot of the providers and physicians that are running those clinics will have to do a very good job, just like Brian and I have to do a very good job of, dispelling those preconceived notions or
Mhm.
those fears that people have around drugs.
Yeah.
Right.
For many years, yeah, we talked about propofol. Vahid, propofol because of
Um, Michael Jackson.
There you go.
exactly. So that proves the point, right? Most of the people that come to us and say, "Hey, what medication are you going to give us?"
Right.
It's now for your endoscopy or for whatever it is. We're going to give you propofol. Oh, that's the stuff that Michael Jackson got.
Yeah.
And you have to prove to them that, but this is a safe, controlled environment. And they'll say, well, didn't he have a doctor that was kind of watching him? Well, he was watching him,
Yeah.
So
right?
it wasn't, I mean, let's just so essentially what we're saying is if it's in a clinic, not at home, if it's
Yeah.
monitored
Yeah.
very carefully, like you guys monitor anesthesia at a hospital.
Right.
You don't do it at home.
Right.
I mean, there's no such thing as an anesthesia clinic, is there? I mean,
not for giving drugs. Yeah.
Nope.
Not that I've heard of.
so I mean, like, could this transform into something that is monitored in a hospital kind of setting?
Yeah, it is. It is like Ankit was talking about those ketamine infusion clinics, right? And so honestly, yeah, I've seen a few of these where there is a provider, whatever they are, a primary care doc, whatever type of
Right.
provider, giving the order for the ketamine and infusing the ketamine, and then an anesthesia provider monitoring the patient with
Right.
full monitors, EKG, pulse oximeter, end tidal CO2, well, treating it like it's an anesthetic. And that, in my opinion, whether it works or not, I don't know, but is completely safe
Sure.
That's the
if you're being
safest way to do it.
monitored.
Right.
Yeah.
That's the safest way to do it. Outside of that, I think there's going to be places that are going to try and flirt with that.
Mhm.
This gets into, do I have enough anesthesia providers to be able to say, hey, can you come work in my ketamine clinic? Or they'll
Right.
get around and say, I've got a nurse practitioner or a nurse. I can watch the patient, which is probably still safe. But here in America, we like to push the envelope.
Mhm.
And so you will find places that will push the envelope and maybe kind of not have the appropriate monitoring that Brian and I would recommend.
Right.
Right.
Was Prince propofol as well, or is
Prince
he
was
something?
Prince was fentanyl. He the
Fentanyl,
the
okay.
theory, I think, and it's been a while since I read this, but I think the theory with Prince is that he was taking hydrocodone, oxycodone, something like that, a normal pain pill for
Sure.
his hip pain, and he got something laced with fentanyl and had died from that. But I think that's still somewhat controversial what he died from and how. But I'm pretty sure they said fentanyl, right?
Yeah, I think so. Yeah.
Yeah.
And fentanyl, that's a very
Same
large
thing.
topic.
Yeah.
But in general, it's to the point now where I think the fear is out there. Some of the gloves that we use, I think Brian, you've probably seen this. The boxes a couple years ago didn't used to write on the box, tested for fentanyl. And
Mhm.
that means that now the gloves that we wear in the hospital have to be tested to be safe for fentanyl so that it doesn't permeate through the glove, because now there's this fear that it can go right through your skin. So because fentanyl is laced with everything now.
Yep.
So
Yeah.
drugs that are on the streets today, you can't be sure what is in them and not in them.
Even marijuana, right? There's stories of people buying marijuana on the street, smoking it, and then either getting very
Right.
sick or dying from fentanyl lacing.
Yeah.
So what is the important thing, I guess, that you both would want the general public to know? Maybe it's a myth that's dispelled around what happened to Matthew Perry. Maybe it's because of the physicians, doctors who are monitoring this. What is the myth maybe, and how do you dispel that?
Yeah, go ahead, Ankit. What do you think?
So I think the myth is that ketamine is dangerous and we should never use it. Let's stay away from it, 10-foot pole. I think that is the myth that will be out there for now for some time. I think the hard work will be for our specialties to talk to patients as they come in and say, hey, yes, you know about the story, but that was not a controlled setting. We don't know what he had in his body outside of that. We never saw the drug screen. We don't know if he had a lot of pills before that.
Mhm.
We don't, so there's so much we don't know. And so it's best not to make a fear-based plan that we as a society want to go forward with and say ketamine is unsafe, don't touch it. But at the same time, I think there's safe uses for it. But even for Brian and I, there are some restrictions that I would kind of have our peers look at. So
Yeah.
Brian, like you said, you don't use it very much. I personally also don't like it very much, and I'll tell you why. So a lot of the patients that we do care for, they are going home. There's a lot of other things that are out there today that can accomplish something similar without using that,
Mhm.
whether it's Tylenol, Toradol, nerve blocks. Now, obviously, Brian and I, we do a lot of nerve blocks, regional anesthesia, minimizing the narcotic use.
Mhm.
There's a lot of things you can do that. And so the reason I say that is because when some of our providers, whether it's a peer or a CRNA that we work with, or someone we're watching and they do give a lot of ketamine, well, they'll say, well, great, that person did amazing. They drop the person off in the recovery room and they wash their hands.
Yeah.
But Brian and I have to will follow that patient all the way through to the recovery room, back to their pre-op bay and home. And what oftentimes I've seen is even those patients that get a moderate dose, they're just ever so slightly kind of out of it.
Mhm.
Just confused to the point where it's not bad, but I would love for someone to be very lucid when they go home. And
Yeah.
so in the elderly population, it's also something to think about. It's as you get older, those drugs like, most of your listeners might have heard of Neurontin or Lyrica. Those are neuropathic type of medications that help with pain management. Even at a certain age, we stop using those because they can just make you feel just foggy enough where yeah, you can go home, but I may not like it.
Yeah.
I
Right.
don't want to be foggy when you're going home.
Yeah. They could fall, and there's all kinds of, especially elderly patients, all kinds of things that can happen. I think the other issue with ketamine is there's no reversal, right? So this is interesting
Right.
story. I'm like 3 years into practice, and there was a patient that I had some issues with, so I used some ketamine. I think it was maybe like 75, 80 milligrams of ketamine, and wouldn't wake up and pack you, wouldn't wake up and pack you. And one of the elder partners in the group called me and said, hey, what's the reversal for ketamine? And I was like, well, there isn't one. He's like, exactly. So
Ah,
that's the other problem is, a
yeah.
lot of the drugs I give, if I give fentanyl, if I give benzodiazepines like Versed, right? There's a lot of these drugs that I can reverse. Ketamine, you just have to wait. You got to wait till it goes away.
So what
So
does the
Right.
reversal exactly mean? So you can get it out of the system somehow?
yeah, make it so it's not working anymore in the body. Yeah.
So imagine you've got a drug and it works on like an enzyme or some
A
kind of binding.
receptor. Yeah. Mhm.
Yeah, a receptor. The reversals help you unbind that receptor, or they flood the system with something else to make it kind of washed out. So
Mhm.
there is a reversal for, like you said, for Versed and for narcotics. Well, everyone has heard of the Narcan, right? So
Right.
Right.
we know Narcan very well. Narcan is that reversal for those narcotics.
And and why not ketamine? Why
Just
can't
there,
you
there
just
just isn't one. Yeah, it hits so
Different
many
receptor.
different receptors. It hits the NMDA receptors. It hits the opioid receptors. It probably hits GABA receptors. There's all kinds of things it hits. So you'd have to reverse everything, and you wouldn't be able to do it.
and
Right.
and what percentage of physicians do you think use ketamine often?
Mm,
Not a lot
I'd
anymore.
guess not very many anymore, but
Yeah, I think not as many anymore in the private practice sense. So now, again, we're splitting well academic centers and private
mhm,
centers, big hospitals and small hospitals and rural hospitals and urban hospitals. But I think the general story is if you have a patient that's going to stay a long time in the hospital or a really big surgery, or you're training residents or fellows, you're probably gonna use it because you probably also want to train them on what it is to be used,
right.
right? Whereas if you get into the veteran places where strictly outpatient joints or strictly outpatient surgery, you've been there, done that. You know what works and what doesn't work. You're not going to experiment a whole lot.
Right.
So I'd say it's still 50%. I think that's out there, but that's probably because a lot of the uses are probably those major large centers.
Yeah.
Are these physicians in the wrong, and why?
For Matthew Perry?
Yes. Is it because of the dosage they used? Is it because what is the
That's a hard question. So is it wrong to use ketamine for the things he was using it for? No. Is it wrong to send, then at least what's coming out now, there was some intermediary who was getting the drugs from a doctor. That's the ketamine queen, getting them from a doctor, taking them to Matthew Perry's house. He was
that was the
using them at his
queen?
home. Yeah. That I mean, I guess I can't say 100%, but that seems very wrong to me. Why would you be
Right.
taking, I mean, if he needs the ketamine, he goes into the doctor and gets the infusion or goes to a pharmacy and buys the pills, although nobody does ketamine pills anymore. So why is there an intermediary? I mean, there's something fishy going on. And then all the
Yeah.
texts that are coming out about how we're going to make him pay $6,000 a day for this. How stupid is this guy? Right. All those text messages that are coming out. So clearly there's something illicit going on. What were you going to say, Ankit?
I think you've had, as a provider, you have to know what's out there and what's not. You have to know where the drugs you're prescribing are getting to. Now, if you're getting it to someone who's an intermediary, that's already right off the bat wrong, right? You have to know that I'm giving this, I'm administering, or I'm watching it be administered, and I'm waiting till that person's safe to go home, and then they go home, right? Outside of that, you're responsible for whatever you write or you allow to be done under your umbrella. And so ultimately that part was wrong.
Yeah.
Well, an interesting topic nonetheless. Yeah. Man, I feel like we went over a lot of information in a short amount of time, but really dispelling some of those myths and rumors that maybe the general public has around ketamine. So it and obviously the point of this podcast is to inform, and we want to inform the public of, hey, maybe the next time you have a conversation with your provider, know this information in the back of your mind, so you can ask some of those questions while you're in there.
Right. Yeah,
I think the biggest thing is to ask questions. Just ask questions. We are well equipped with the answers. You have to just know that it's okay to ask, right? I'd rather you ask a lot of questions and keep me in your room for a lot longer than you to keep this fear with you that'll last generations. Right.
I think that's I mean, sorry to interrupt. I think that is, I was in the hospital with my wife, and the doctor is like, hey, do you have any questions? It's a completely different subject matter. However, talking about asking the provider questions, I think we're scared to ask questions because, how is it going to be perceived? Are they going to think that we're stupid? Or, I think there's so many things but at the end of the day, it's my health, right? Number one. And number two, you're the expert that I'm coming to get that information from. So why shouldn't I be able to ask you 10 questions if I had 10 questions?
I mean, you ask your mechanic, right? You ask your mechanic those questions. You ask your lawyer those questions. Why wouldn't you ask your doctor those questions?
Absolutely. It's your body and it's your health. And truthfully, if your provider or doctor or nurse practitioner or CRNA isn't willing to, that's bad on them. Your expectation is to ask questions because you want to know about your body. Your body is your temple. So I think Brian, would encourage you to ask every question you can think of.
Yep. Yeah, absolutely. And I'm sure now we're going to get lots of questions about ketamine. Great. We're happy to answer them. I think there's some other things we're talking about, obstetrics and stuff, and Ankit and I have talked about this before, is epidurals and spinals. People are really afraid about those as well. Am I going to get paralyzed? And I always, this is my standard line. I say, in the literature, I've seen 3 reports of paralysis from a well-done normal patient, epidural, labor epidural, or a spinal. So that's 3 in the multi-millions, tens of millions, maybe hundreds of millions that we've ever done. So your risk is infinitesimally small.
Right. And the benefit so far outweighs that risk. There's no reason for you to come into the hospital feeling like you have to power through or feeling like you have to subject yourself to this pain. There's no reward for you at the end of the line, that no one's going to give you this medal that you did it without, when there's such a great opportunity for you to ask those questions and for us to explain to you what it is. What is an epidural? Your baby won't get those medications. And we can talk about it another time too, but I spend a lot of my time with OB moms talking about, well, why is it that you don't want an epidural? Ask me questions. Let me kind of help you through it, not to force it on you, but to really help you understand that if you did feel like there is an opening, we should do it. You don't want to wait to the last minute and say, no, now I want one.
Right.
Sometimes it's too late.
Yep.
But ahead of time,
my wife, the
Heather
first
knows,
time
yeah.
around, it was too late.
Yeah.
See? And I think that there's a whole culture with like, well, I don't want it. I want to see how it goes without. I want to see how it goes without.
Right.
You don't have to. You just don't have to.
Right.
If we do our job and explain things to you the way we should explain it and dispel those, I'm talking 50, 70 years, generations of fear around being paralyzed with an epidural. I think I've made a long way, but I think there's a lot more room to grow for us.
Well, I think we need to do I think we need to do a full podcast on that. That's a great topic.
Yeah, absolutely.
The number of moms that are out there that either had kids or are going to have kids, it's a very big topic, and I think it's important for us to get there because moms come in, they wait till the patient or they are 9 centimeters just far along, and they say, well, now I want one. Well, now you can't sit up because you're having so much pain. We can't do it. And I feel so bad that I can't do it.
You ever do labor spinals? A couple of our providers do some labor spinals, which is cool. And I guess I'll share real quick. You get to a certain point, an epidural is not going to kick in fast enough.
Right.
Spinal, though, kicks in like that. Now, it only lasts 45 minutes, an hour, maybe 2. So several of our providers that do a lot of OB will go in and they're 9.5 centimeters, labor spinal, get the baby out, episiotomy, whatever, placenta out, all that kind of stuff. And then it wears off and you're doing well, but it kicks in fast enough. So that's another option, right?
Yeah, and it's perfect to the point where assuming you get the provider up there fast enough.
Yeah.
But it's perfect because sometimes you're just barely finishing and the baby's on its way out.
Yep.
And so the labor spinals are great. Ideally, we'd not want to get to that point, but if we have to, we'll do it.
Right. Absolutely. Yeah.
Well, gentlemen, thank you so much. This has been really informative. Obviously, I always preface the conversation by I'm the only non-MD in the room, but I can speak for most of the general public, right, that comes in and has questions about, hey, what's going on and what do I need to ask, and getting some of that information. So
yeah, absolutely.
You can have me on board.
Why the Eagles again? Because I got to ask about the Eagles.
We didn't.
You live in Ohio? Are you a Browns fan, or are you?
So I grew up in Youngstown, Ohio, and it happens to be that the DeBartolo family, who owns the 49ers, from Youngstown. So I'm a Niner.
Okay.
I'm a Niner.
So I'm a Colts fan when you talk about professional football, but growing up, I grew up in Zionsville, Indiana, and our mascot was the Eagles. My oldest son just started playing tackle football, and he's on the Eagles now. So I got all the gear. I'm super psyched about it. He had his first game yesterday.
Well, that's the first thing I saw when I saw it. I was like, oh no, are you an Eagle fan? I can't do an Eagles fan.
I'm a Zionsville Eagle and a South Bend Rocket League Eagle fan, not a Philadelphia Eagle fan.
There you go.
My son got his jersey yesterday, and he's part of the Bucks organization.
Oh, the Bucks. Okay, all right. For flag, right?
For flag,
yeah.
right? For flag.
For flag, mine are Chiefs. But
oh, Chiefs. Okay, yeah. He's doing tackle football now.
Is he?
No, you're.
Oh yeah. My older
son
is. Yeah.
I can't do Chiefs either, unfortunately. The Niners seem to have a lot of rivalries. So
Packers are one of them, and I grew up in Wisconsin, so I'm a diehard Packers fan. So don't hold that against me.
You can't hate on the Colts, though, right? I don't think we have any rivalries with the Colts, right? No. Yeah. So Patriots, yeah, but he's not a Patriot fan.
No,
so we're good. And the Packers, Colts, no. Colts, Niners, no. We're good.
Colts fan. I wish that Andrew Luck played longer than he did.
That's right.
Oh, don't get me started on that.
Yeah, you could go all day on that one. Well, thank you so much, Doctor. Thank you so much, Dr. Brian Schmutzler. This has been Going Under, and don't worry, this is not going to be the only podcast that you see these two on in the near future. More about that in the coming days and coming weeks. But for now, this has been Anesthesia Answered with Dr. Brian Schmutzler, and we'll see you guys in the next one.
Thanks, Ankit.
Thank you. Appreciate it, guys.